So this voiceover is going to go over some injuries to the musculoskeletal system, and in particular that of fractures and the care of children with fractures. So obviously we know fractures are a break in the bone that occurs when stress is placed on that bone, but they are frequent in children because their bones, as you recall, are less dense and more porous than those of the adult world. So fractures will manifest themselves with pain. It depends on where the fracture is, but pain, they will have some immobility or decreased range of motion. They may be guarding that particular bone or extremity. Childhood fractures commonly involve the clavicle, the tibia, the ulna, and the femur. And the distal forearm fractures are the most common in children. Stress fractures, which is something a little bit different, fractures caused by increased stress, just as it says on the particular bone, are most common in the tibia, the fibula, and the metatarsals. And they are becoming much more common. We are seeing stress fractures a whole lot more frequently in the adolescent population, as though that is a population that is often limiting their intake of calories and calcium. Epiphyseal injuries are dangerous in children. Remember that they can interfere with the growth of that bone in the future, and so injuries to that area are of great concern. This slide just shows you the different types of classification system used for fractures at the epiphyseal plate or the epiphysis. And you can see that there are very common ones, the most common being type 2. And you don't need to know this for the exam, but it is important to know the different types of fractures that can occur at that epiphyseal region. So in terms of fractures, there are two prongs of treatment. The first is to reduce and align the displacement and fragmented bones, and that is done in one of two ways. So we can either do closed reduction that will align the bones by a manual manipulation. And it's important to remember that we will use conscious sedation and pain management to do that process. The other method for reduction is open reduction, and that will require a surgical realignment. Once we have reduced the fracture, the next step is to immobilize that fracture, and that can take place in a myriad of different ways. Casting, splinting, or traction can be used, and we use them all in children. With casting, what is important to remember is that it does immobilize the joint. It does allow us to keep the joint immobilized without using traction, so the child is much more mobile. There are certain things that we need to remember to do with casting. We need to perform frequent neurovascular checks, and that done more frequently in the beginning, and we can back off a little bit after the child is deemed stable. But that initial phase where we've put the cast on and there could be swelling in that limb, it's important to watch for circulation. We need to be looking at capillary refill, color, warmth, etc. in that area. We need to elevate the limb as much as possible and assess for compartment syndrome. This is a dangerous side effect that can occur, and it's caused when there's increased pressure in a very limited space, like the soft tissue of an extremity, and it will compromise circulation and nervous intervention. Patients can lose a limb in this process. This is dangerous, and we need to manage it and watch it closely. Managing itching is a big issue, especially with children. It's really hard to get children to not scratch at things, and so this can be a real issue for children. Sometimes we will treat them with antihistamines. Using cool air sometimes helps children as well. Distraction obviously would be the best method. And then we do need to make sure we teach parents cast care. We don't want them to speed the drying with heat or fans. It needs to dry normally. And one other thing that it really happens a lot with children, especially when they're young, is that they will put small toys, foods, and items down into the cast. And we need to remember to keep those kids managed and watched and supervised so that that does not happen, because it is not unusual to open a cast on a child and find food from the meals that they have had, or small toys, Legos, paper clips, buttons, etc. The last slide talks about the different types of traction. There are different types of traction. I do not need you to know those specific types of traction, but what I do need you to know is that there is specific care that we need to manage with traction. One, we need to watch the pins that are used to secure the traction devices to and make sure that those remain infection-free. And that we are doing pin care on those. And we need to watch for circulation neurovascular assessments continue to be important whether we are using casts or whether we are using traction and pins. So it's important that we are always paying attention to those assessments, and you will learn more in your other GNP classes about the forms of traction and how they work.